of course, I started this town hall on mute. I apologize for that. Isn't this the world we live in? All right. Hello, everyone. Without further ado, I want to welcome you to this virtual town hall discussing COVID-19 and vaccines. My name is Farah Nasser. I am the anchor of Global News here in Toronto, and I'll be your MC for this very important discussion hosted by the Sinai Health Foundation. And I just want to thank all of you for being here. We have really received such an overwhelming response for this town hall with, if you can believe it, over 2,000 registrants. And, you know, in this world where we are all zoomed out and you parents out there are virtual learning out probably with all the screens that we have in front of us, it really is a testament to how important this conversation is and how important the work and expertise of the people on our panel is right now as we talk about vaccines and the future and what we're going to see in the next few months when it comes to the vaccine rollout here. Now, we are live right now on our mainstream. We are also live on YouTube and on Facebook. And we are also going to be sending you a recording after this so you can share it with anyone who wasn't able to join today and wasn't able to watch this panel. So we'll be sending that to you as well. For those of you who are new to Sinai Health is Canada's leading integrated health system and biomedical research institute. Sinai experts are globally recognized for women's health, pregnancy, some of the most complex chronic illnesses, healthy aging. I am really proud to say that I was a former board member of the Arthritis Research Foundation. Autoimmune diseases and arthritis run in my family. And the fundraising we did, the money we raised has really led to so many advancements in that area. So very excited to be here and proud to help out when it comes to Sinai Health. So today our experts, our Sinai Health experts, they're here to discuss COVID-19 and the vaccines that have been deployed and that are rolling out across Canada and that are rolling out really across the world. We have two experts today. We have Dr. Howard Ovens and we have Dr. Allison McGeer, and they're going to share with us some information. They're going to also answer some of the questions that you've submitted. We've received hundreds of them, and we encourage you also to submit questions in real time as well. So without further ado, I'd like to welcome our first speaker, Dr. Howard Ovens. Dr. Ovens is the Chief Medical Strategy Officer for Sinai Health and Medical Advisor, Sinai Health Foundation. Dr. Ovens, over to you.
Well, thank you so much, Farah, and thanks to Dr. McGeer for joining us today, and thanks to all of you for joining us and for your interest in our topic and in Sinai Health. And Farah, thanks for your support for our research program in arthritis. So I'm just going to take a very couple of minutes very briefly to update everybody on sort of where we are putting today's discussion on vaccines in the future in a little bit of a present context. And as of this morning, Ontario was reporting just over 1,000 new cases of COVID-19, 1,022. Tragically, another 17 deaths. Yesterday, we did 30,000 tests in Ontario and had a 3.3% positive rate on those swabs. We currently have 909 people hospitalized in Ontario with COVID-19 and about 360 patients in critical care in our ICUs. As far as there's been a lot of talk about variants, and of note, we have so far identified 227 of the so-called UK variant in Ontario and 3 of the South African variant. And most ominously, we cannot trace all of those back to travel-related cases, indicating that they are probably circulating in our community already. Here at Sinai Health, we're down to 11 confirmed COVID cases, only one of which is in critical care. We've been mainly seeing cases here that have been transferred from other hotspots around the Greater Toronto area. And actually, Sinai Health has taken more of these cases in transfer than any other hospital in Ontario, although we are getting a bit of a break from the system this week, especially as the new hospital in Markham comes online. All the numbers I quoted are in fact headed in the right direction and are down from our peaks several weeks ago. But in context, the numbers are still high. They're higher than the peak of our first wave. And contact tracing is still overwhelmed with well over half of our cases continuing to show no known source or no information available. And we know that the new variants which are circulating are, in fact, more transmissible than the first version of the virus. So we can't vaccinate our way out of this current wave. And therefore, I and many of my colleagues are very concerned about the fact that Ontario, as well as Quebec and Alberta, are loosening restrictions. Schools are reopening, which is probably a good thing. But ideally, I think we should have held on for 2 to 3 weeks after school reopening to see the impact before making other changes. And this is discussed in some detail in this morning's Globe and Mail editorial. I think the bottom line for us as individuals is that we have to maintain our vigilance and keep to our precautions. Stay home and get tested if you don't feel well. Limit your interactions outside your household to essential purposes only. Wear a good mask and keep a distance from other people when outside your household. This is true regardless of whether you've had COVID in the past, because there remains a risk of reinfection, or whether you've been vaccinated, because there also remains an unknown risk of asymptomatic or mild disease, which would make you contagious to other people. So that's where we stand today, February 9th, and I'll give it back to Farah to take us to our next speaker.
Thank you for that, Dr. Evans. We can't vaccinate ourselves out of this current wave is something I'm going to take away from what you just said, and I look forward to talking about that further. I'd now like to welcome Dr. Alison McGeer. Dr. McGeer is a senior clinician scientist at Sinai Health's Lunenfeld Tannenbaum Research Institute and is an infectious disease expert that you may know. She's been on our screen a lot on Global News. And today she is researching COVID-19 and of course has a lot to say about the vaccine. Welcome, Dr. McGeer.
Thanks, Farah, and thanks everyone for having me and for being here for this conversation and for Sinai Health. I think we're going to shift to slides. I'm told this is a mark of a true academic that you can't talk without slides in front of you, so I'm sorry, you're going to have to live with seeing slides. So this first slide is a list of the 7 vaccines that we currently have contracts for in Canada. You'll recall that last September, when vaccines seemed a very long way away, we attempted to spread risk by starting contracts with a number of different vaccine manufacturers. And so far, 2 of those, in green, the Pfizer and Moderna mRNA vaccines, are authorized in Canada. There's 3 more, the AstraZeneca, Oxford, Janssen, and Novavax, that are currently being assessed by Health Canada. And then, as you may have heard, the Sanofi GSK vaccine's been a little delayed. We're not expecting it until probably September next year. And Medicago is our one Canadian manufacturer that's on that list with contracts, a company out of Montreal that is also a little bit further behind than the others. One of the really important things to recognize as we get to vaccines is that the road there is going to be bumpy. We've already seen a number of bumps. You know, we've had trouble with vaccine supply from different manufacturers. We're talking now about the AstraZeneca vaccine and it not covering the South African variant. Every week or 2 weeks, this is a pandemic, there's going to be something new and different about the vaccine. Some of it's going to be good, some of it's going to be bad. But it's really important as we move through this to try to take the pieces in stride and to know that we are moving forward, even though we're not necessarily moving forward in a straight line. Next slide. Now, a little bit about how we make vaccines. Our old standard technology for making vaccines is harder than it looks, okay, but in principle is really simple. You take a virus, say, like COVID, you look for the proteins that best stimulate our immune systems to provide us protection from real infections. So you see them up here labeled M and spike. All of our current vaccines to COVID are with spike protein, which is the major protein on the surface. You purify those proteins, And then you inject them into usually the muscle cells, sometimes subcutaneously, often with something called an adjuvant, a compound that stimulates the local immune system so you get a better local reaction. When that protein enters your muscle, your body recognizes it as foreign, something that needs to be destroyed, and you mount both an antibody response and a T cell response that deals with the protein that's been injected, but also means that you have memory cells there that are ready so that when you get infected with COVID, your body responds much more quickly and efficiently than it would otherwise, and you deal with the virus and kill it before you get sick from it. The vaccines that we now have, some of the vaccines that we now have, Novavax is a protein-based vaccine, but we've now got a bunch of other different technologies for vaccines. Next slide. And the first of these are the RNA vaccines. You end up in the same place that you got to with the protein vaccine, but by a somewhat different route. mRNA, or messenger RNA, is RNA that takes messages from the nucleus of your cell where your DNA is and tells the cellular machinery what protein you want it to make. So to make an mRNA vaccine, you create a piece of mRNA that encodes, in this case, the spike protein of COVID. You coat it with little lipid nanoparticles. That's both for stability, because RNA is very unstable by itself, and so that it enters into cells. And when you inject it, those lipid particles get into the cell, release their messenger RNA. The messenger RNA tells the cellular machinery that it wants the cellular machinery to make spike protein. So you get spike protein, and now you're back to where you were before. You manufacture spike protein, your immune system recognizes it as foreign, you mount an immune response that allows you to practice and makes you ready for COVID should you need it later on. mRNA is quite unstable, so you get a short burst of spike activity, and then it stops as the mRNA is discarded. And we were actually, all of us, really worried before the mRNA vaccines came that they weren't going to be very effective. It was, I think, the top of people's concerns, because it's been actually very difficult to make mRNA vaccines, even though people have done a lot of work on it. So it's been a really pleasant surprise to find how effective the mRNA vaccines that we currently have are. The AstraZeneca vaccine and the Janssen vaccine are a different kind of vaccine called a non-replicating viral vector vaccine. So these vaccines take a virus, they incapacitate it so that it cannot multiply, and then they insert the spike protein gene into the virus, again with the effect of the virus itself making nothing but the spike protein. So when you inject it, for as long as the virus survives, which is a matter of hours or days, it makes spike protein. And now you're back where you started out before. You get spike protein in your muscle, your immune system responds to it. You've practiced, you deal with COVID the next time. So for the first time, we've got a range of different approaches to how to deal with COVID and get vaccines out. And that's serving us very well. You'll notice that the protein vaccines, the old technology, the Novavax, are coming later. So while having brand new technology for vaccines has been a little bit scary, it's actually a tremendous advantage because it's given us vaccines about 3 months before we would otherwise have had anything to deal with the pandemic. Next slide. Okay, so how well do they work? Well, the Pfizer and Moderna vaccines in the short term, and that's all we know now, work very well indeed. So they prevent about 95% of all infections. The AstraZeneca vaccine is not quite as effective, and here's another bump on the road. You may have heard the news in the past couple of days that South Africa is temporarily suspending using the AstraZeneca vaccine because they're worried that it doesn't work as well against the South African variant. We don't have those data for Pfizer and Moderna because the South African variant didn't exist when these vaccines were tested. But it looks like they are effective against the South African variant, or at least almost as effective against the South African variant. Janssen & Janssen and Novavax coming along behind also look very effective, although both of them, you see the difference here between the US and South Africa, and in the Novavax, the difference between the original strain and the South African variant, they're not quite as good against the South African variant. All of these vaccines so far are very protective against severe disease. But even when you do trials of 30,000 people, generally they're younger, healthier people. There's not a lot of hospitalization in that group. So we're still waiting for data on how well all of these vaccines protect us from serious disease. Next slide. Okay, now, everybody's first reaction when the mRNA vaccines appeared seemingly out of nowhere was, but they must have come too fast to be safe. Right? Usually vaccines take years and years to produce, and our previous record, granted it was 40 years ago, and we've learned a lot in the last 40 years, was 4 years for mumps vaccine. So in order to think about why we have vaccines so quickly, you need to remember a bunch of things about this pandemic. The first is we've been planning for it, okay? For 20 years, we've known that there are pandemics coming. We've known that we'll need a vaccine to get out of them. And so there's a tremendous amount of work that's gone into when we have a pandemic, what do we need to do to make sure we get vaccines as quickly as possible? And the most impressive thing, the thing that shortens it the most, is that instead of doing things linearly, the way you normally develop a vaccine, things are being done at the same time. So usually when you develop a vaccine, you do a phase 1 trial, you look at the data, you go to phase 2, you look at the data, you go to phase 3. Phase 3 trial works, you take it to the regulatory agencies who look at it. If they approve it, then you go to commercial production. Then you have to do some more studies, lot to lot variation. All this takes time, as you can imagine. So what we did with the COVID vaccines was we said, we have to have faith that some of these vaccines are going to work. And so we built the manufacturing plants. We did all the studies with commercial grade vaccine with varying lots. So everything got done at the same time instead of being all stretched out. The result of that was this unbelievable thing where government approved them one day and they were in Canada 2 days later, which never happens. And I think for everybody it was just a little bit shocking. But that, if the vaccine had not worked, and it might not have, that would have been a mind-numbing amount of money that we had spent on vaccine production. But it's just a marker of, relative to the economic disruption that's going on, relative to the number of deaths from COVID, that amount of money is nothing, right? So it's not something we would normally do at all, but it is a critical component of why we got them so fast. Next slide. And it's not, in fact, that we compromised on safety at all. The safety standards are unchanged, and safety standards for vaccines are very, very high bars to meet. However, it seems much more obvious with this vaccine that we don't know a bunch of things when we start using it. The truth is, anytime we start using a vaccine, we don't know how long it's going to work for. We don't know all the population subgroups and whether everybody's going to be protected. And we don't know whether there are going to be rare adverse events. And there's nothing you can do about that. If we waited to know how long hepatitis B vaccine would have lasted, we still wouldn't be using it, okay? It's 50 years, it still works, okay? So you have to start with, we know this vaccine protects people for long enough and well enough to be important, and then you watch over time and you adjust your program like second dose measles vaccine as you find out how the vaccine works over time. When you do studies of vaccines, usually the big phase 3 studies that demonstrate that a vaccine works have 20 or 30,000 people in them. And those people get looked at very carefully for adverse events. But if you have an adverse event that happens to 1 in 2 million people, you're not going to detect that until you start using the vaccine. You just can't have that. So when we start using vaccines, it's always possible that there's a rare adverse event that we don't know about that we need to be watching for very carefully. Next slide. I'm going to come back to that in a minute. So how's vaccine rollout going in Ontario? Priorities for any vaccine in Canada are developed both federally and provincially, right? We're a federation and health is a provincial responsibility. So we have a national advisory committee on immunization that writes general guidelines about what they think are important priorities for vaccine programs. And then each of the provinces takes them and fits those general priorities to the particular issues in every province, because Prince Edward Island is not Nunavut, is not British Columbia. So this is what it looks like in Ontario. It's actually very similar to the other provinces. We've all agreed that staff, residents, and caregivers in long-term care and retirement are our top priority because this has been such a devastating illness in long-term care. We've all agreed that frontline acute care hospital healthcare workers are a priority for reciprocity and because we depend on them to maintain care for COVID patients. Then there's First Nations, Inuit, and Métis adults, both in urban areas and in remote communities, home care clients and staff. And then we're moving to adults by age group, okay? And most provinces are starting at 80 years as the first cut point. So you can see if you look at that's about 1.5 million people in Ontario, and you need 2 doses of vaccine. So somewhere between 1.5 and 3 million first doses of vaccine are going to these groups of people, and then we will move on. And at the rate we're moving, okay, so far we've had 400,000 doses of the 2 or 3 million that we need. We're expecting 60,000 this week, and then we're going to ramp up probably to 100 or 150,000. So we have some weeks to go before we start moving to younger age groups. One of the really important and different things about COVID that makes it so hard to absorb the priorities is that we're used to giving out vaccines by underlying illness. We think, okay, people over 65 and people who have underlying illnesses, but COVID is different. And for COVID, there are 2 big risk factors that you have to worry about first before anything else, and that's age, much more dramatically than other diseases, and socioeconomic status, crowded living conditions. So in Ontario, for instance, if you take older people in the areas that have the highest COVID rates, so the postal code area, forest rotation areas have the highest postal code rates, you can prevent 50% of the deaths by vaccinating about 400,000 people. So, and that's what we're trying to do, right? We're running these vaccine programs first and foremost to prevent death and hospitalization. So patients, incredible amounts of patients are going to be required by all of us to wait for vaccine to come, but it is coming, and it's going to come at increasing speed over the next few weeks, and probably sooner than you think is possible, it will be arriving at your door. Next slide. Okay, now, one of the 2 other small things, one of the big things we've been talking about is first dose versus second dose of vaccine. This slide's a little bit complicated, but if you bear with me for a moment, it shows you why we're having this discussion. When we made the mRNA vaccines, we assumed that you were going to need 2 doses. Remember, we were worried they weren't going to work very well. So we said people are going to need 2 doses to get a good enough immune response to protect them from COVID. And we want to make those 2 doses as close together as possible because this is a pandemic and we want to get protection to people quickly. So this is the study. This is the Pfizer-BioNTech vaccine, although the Moderna vaccine data look very similar. And the blue line are the people in the trial who got placebo and the cumulative number of COVID cases in that group. So you can see that there's a nice stable risk of COVID all the way through the trial. People kept getting infected. The yellow line are people who got vaccine. And the inset is the detail of the first 3 weeks. So what you can see is when you get your first dose of vaccine, nothing much happens for the first 10 days. People continue to get COVID infections at the same rate. And then all of a sudden, the people who get vaccines stopped getting infected. So the first dose was actually, after 10 or 14 days, was actually very effective, about 85%, maybe not quite 95, but very close to 95% efficacious in preventing infection. You almost certainly need a second dose of vaccine. It'll get you a boost. It'll protect you for longer. It may protect you better against variants when the variants come, but you don't need it for the first few weeks or months. That was completely unexpected, okay? And so it's taken everybody a little bit of time to look at that and absorb it and say, you know something, if we need to delay second doses in order to get first doses into people who are vulnerable, that's a very sensible thing to do and will result in better protection for the majority of people in the population. So the take-home message from this is if somebody says to you, your second dose of vaccine is going to be late, you're going to say thank you because you know it's not going to harm you. The first dose is enough. And because you know it means that your second dose of vaccine is being used to protect somebody else in the short term while you're waiting for your second dose. Next slide. Okay, really quickly, who can't get vaccinated? The top is the important thing. There is a component in these vaccines called polyethylene glycol to which you can be allergic, although it's really uncommon. And if you have a known allergy to polyethylene glycol, then you cannot get these vaccines. Got to wait for one of the other ones that are coming. And we're not yet vaccinating children because children are not seriously ill from COVID. And we need to have data on safety and efficacy in children before we routinely recommend it. So people under the age of 16 should generally not be vaccinated now. Next slide. Okay, so how are we doing in vaccines? Well, you can see that Canada's nowhere near the bottom of the list in proportion of vaccinated, but we have been falling a little bit behind as our shortages of vaccines have been in the last 2 or 3 weeks. We will be catching up soon. The main point of this slide is because the United Kingdom and Israel and the United States have been using Moderna and Pfizer vaccines, there have been large numbers of vaccines administered. So we're above 50 million doses of Pfizer and Moderna. And the good news about that is that's enough to detect really rare adverse events. If there was a rare adverse event that occurred with these vaccines, we would know about it. And we do know about one called allergic reactions. Anaphylaxis clearly happens with these vaccines and at a slightly higher rate than occurs with other vaccines, but is still really low. So it's about 2 per million doses of the Moderna vaccine and about 5 per million doses of the Pfizer vaccine. So not nothing. And important that when we're running vaccine clinics that we can respond to anaphylaxis, but still a very, very low rate of anaphylaxis. And at the bottom of this slide, if you're obsessive about vaccine safety, ACIP, the Advisory Committee on Immunization Practices in the United States, just had a presentation on the safety surveillance systems in the US, which is worth looking at if you're either worried about vaccine safety or just interested in how vaccine safety systems work. A really lovely illustration of what's being done in the United States to watch for vaccine safety. Next slide. Okay, lastly, what about variants and vaccines? The first viral variant that we're going to have to deal with is called the UK variant. Notice that as we've all gotten tired in the pandemic, we forgot that we were not supposed to be naming viruses geographically, okay? And eventually somebody's going to rename this, but for the moment it's the UK variant. And it's clearly in Canada and being detected in people who have acquired the infection here. So we are going to have to live with it. And to give you a sense of what the timing looks like, the dark purple bars here are close to 100% of isolates are the variant. So you can see that in the UK, this variant started in the southeast in Kent. And at the beginning of December was really uncommon. So the white is sort of 0 to 10%, which is where we are now in Ontario, in the north and central parts of the UK. And then over a period of 8 weeks, you see that variant take over the entire country. So now about 80% of all infections in the UK are the UK variant, and that's what we're expecting to see. So we're having a little trouble with figuring out just how quickly it's moving. Sometime between the end of February and the end of March, most of our infections in Ontario are expected to be the UK variant, and that, of course, is a problem, not because it's much more serious, but because it's much more transmissible. We will need to do better than we are currently doing in order to achieve the same effect on the UK variant as we're achieving on a regular virus. And that's why Dr. Evans and many of the rest of us are so worried about what's happening with the release of restrictions now. If we release restrictions too quickly, the viral variant will intersect with that, and suddenly our cases will climb rapidly again, and we'll end up in lockdown. And what worries me most about that is, not so much that we'll end up in lockdown, but that we'll have to close schools again, which is what happened in the United Kingdom. And hopefully, if we can open schools and keep everything else under control, then there's a reasonable possibility that we can maintain schools. And so that's what I'm hoping for, that we will all do our best to keep our contacts to a minimum, to be sure that we're masking and maintaining our distance, and that we will get away with having schools open and dealing with the variant at the same time. Good news about the UK variant: vaccines work against the UK variant. Bad news, as Dr. Evans has pointed out, that we do have some isolates of the South African variant. We don't know what's going to happen to them now. They may not outcompete the UK variant. That would be good if it happened. But people are going to be watching very carefully because although there's pretty good evidence that our current vaccines work well against these variants, that's something we don't know with certainty at the moment. I think that's the end of the slides. Thank you.
Okay, Dr. McGeer, thank you so much. So much information there. And as you mentioned, I mean, not only are we seeing this loosening of rules and restrictions, we're also seeing school opening at the very same time. And I interviewed a statistician yesterday who said if schools are the priority, then schools should be the priority. So everything is happening in the next few weeks together. We have so many questions to get to. In fact, we've had more than 450 questions sent to us, if you can believe it. But we're still open to your questions. If you're watching us, you can submit them through the chat. And of course, we'll try to answer as many as possible. I'm talking a little fast because we don't have a lot of time and we have so many questions to get to. I just want to remind you of one more thing as you're watching us before we get right into this chat, this Q&A. We have the foundation, Sinai Health Foundation social channels. They're linked to the page that you're watching right now. So be sure to follow us for future initiatives, dates, and future events. And the page is going to open on another window, so you won't lose the feed that you're watching right now. So with that, Dr. Evans and Dr. McGeer, are you ready to get started?
Yes.
Let's go.
Great. Okay. First, you mentioned, Dr. McGeer, you had that priority list, which you put so well, and I took a screen grab of it, so I remember it as well. But I think a lot of people are still wondering when. So if I'm not in those first four categories, if I'm somebody who is 75, 80 plus, 40 years old, maybe even below 16 years old, we got this question several times. When do you think I'll get the vaccine?
So it's going to be dependent on two things: how quickly vaccines come and exactly what age you are. We're going to move through those groups. I think everybody's hoping that by the end of March, we'll be talking about maybe people who are between 60 and 70 and moving into essential workers. But it is going to be dependent on how quickly vaccines flow, and to some extent how well we do with delivering those vaccines. So I think people have been afraid to open their mouths and put a deadline on it because it's a pandemic and things are much less predictable than we'd like them to be.
Let me follow up with that because the Prime Minister has put a date on it. He says by September, everyone who wants a vaccine will get a vaccine. Is that realistic?
It's reasonably realistic. If we work really hard, it might happen. But I think there are still rooms for issues with a vaccine failing or with us having to reformulate vaccines to adjust to the new variant. So I don't think it's a guarantee. I think November, December is maybe more realistic.
Okay, and of course it depends on all the supply chain issues as well, which some are completely out of our control. Okay, now this is a follow-up to that question from someone watching, and that is, how will we be notified when we receive the vaccine? Is there anything we need to do ourselves? Do we need to sign up? How can we prepare?
I think somebody suggested the other day that we should have a national sign-up system for the vaccine so that we would all feel better about having let people know that we want it, that we were on a list somewhere. But the truth is that it'll be in the media. If your family doctor is delivering it, your family doctor will be in touch with you. If your pharmacy is getting it in, your pharmacy will let you know. So we're going to know when it's coming. I'm not worried about the fact that people are going to be left out and not going to find out that vaccine is coming. But you're right. It would be nice if there was some mechanism for each of us to be able to say, I'm in line here. Can you let me know, please? I don't think we're going to get to that. I think it's a bit too chaotic for that at the moment, but you don't need to worry. You will find out when you get your vaccine.
Is there anything happening right now, like any sort of rollout plan that the province is doing to prepare for this?
Oh, there are hundreds of people working on these rollout plans. Yes. Okay, you don't see them or hear about them, but there are people in local public health, in the Ministry of Health, at Public Health Ontario, all over the province who are working on building these plans so that as soon as the vaccines come, right, goal is to keep our freezers empty. Okay, as soon as a vaccine comes in, it's out, it's into people's arms. And all of the public health units have these now very extensive plans of how vaccine is going to be delivered as it comes.
Okay, Dr. Evans, this next question is for you. What does it mean if I'm vaccinated? Could I still spread COVID-19, and how long would I be immune for?
Well, I'll take the second part first. As Allison alluded to in her presentation, we can't know that a vaccine lasts for 2 years after only 3 months. It's just not possible. What we've seen so far is that immunity does seem durable in the time since we started testing them. And so we're optimistic that it's certainly going to last a year or more. Some of that will also depend on genetic drift of the virus, but we really don't know. The other thing we don't know is because in order to get the phase 3 trials done as timely as possible, they really only swabbed people who didn't feel well. So we're not sure what the vaccine's impact is in preventing either asymptomatic disease or very, very mild disease. And those studies are ongoing now, but until they're done, we have to assume that it's possible, and there's theoretical reasons about immunity and how it goes from sort of our bodies into our nasal passages and things like that. There are theoretical reasons to believe that it's possible that the vaccine could keep you safe, but would not totally prevent you from being a vector who could spread the disease to other people around you. So as a result, people who are vaccinated must continue to take precautions and wear a mask publicly and really behave just like everyone else. So your life will not immediately change once you're vaccinated. And a lot of people have asked about immunity passports and special privileges. 75 healthcare workers who were vaccinated got to go to the Super Bowl on Sunday. Really, until we know more about the risk of transmission in people who've been vaccinated, you will not see any documentation or privileges related to having vaccination status. You have to follow the same rules when you go grocery shopping. If you go traveling, you'll have to quarantine, take your test before you return. You really will have to act just like anybody else.
Is that because it's not, we don't have that big population that's vaccinated? That's the reason for that, right? It's just
we don't have a big database yet on the effectiveness of the vaccines at preventing very mild but transmissible illness.
Okay. I know you mentioned this, so I want to go through it rather quickly. Dr. McGeer, you said that with autoimmune illnesses now, it's okay to take the vaccine. You also talked about pregnancy and breastfeeding. Can you just quickly go over that again? And if there's any exceptions, I mean, chemo patients, for example, we had a few emails come in, people who had kidney disease.
So So for many of those diseases, autoimmune diseases, people who are on immunosuppressive therapy, people who are getting therapy for cancer, those are all circumstances where you might not respond as well to the vaccine as you otherwise would. And so the original NACI recommendation about that was not to vaccinate those people because they might not respond well to the vaccine. And then we took a step back and said, well, just wait now. We're in the middle of a pandemic. These are people who are more likely to develop severe illness if they get sick. The vaccine may not work as well, but it almost certainly has some benefits. So it doesn't make any sense to say, do not vaccinate these people. And that covers everybody, people on dialysis, people who are getting chemotherapy, people who are on immunosuppressive medications, people who have autoimmune diseases, all those people, when their time comes, when their age group comes up, should be getting the vaccine for their own protection. And over the next few months, we will see very quickly data coming out about how well these vaccines work in these populations. For pregnant women are a little different. We really worry about pregnancy. And so we're not going to make a routine recommendation until we know with confidence that the vaccine is safe. And those studies are running now. But we have now said that a pregnant woman can make her own decision. She needs to look at what her risk of COVID is, how she feels about the potential risk to her fetus, and make a decision with her care provider about whether it's sensible for her to get the vaccine. And in general, the obstetrical associations have suggested that it is entirely reasonable for pregnant women to choose to get vaccinated.
Can I just ask, what about for those who are anticipating being pregnant? So maybe they're not pregnant now, but they're planning to have a family soon.
Yeah. So for people who are thinking about being pregnant, for people who are breastfeeding, there is absolutely no reason not to get vaccinated. Those people should be vaccinated. We know that when people are pregnant, they are at some risk of pregnancy loss and of more severe illness if they get COVID. So you really want to be vaccinated before you get pregnant.
Okay. Would you be able to discuss the vaccine and severe allergies in a bit more detail?
Yeah, for sure. Any medication or vaccine can give you an allergic reaction. There's always something in them, no matter how simple they are. And so it's not unexpected that these vaccines are associated with allergies. And we have numbers for the severe allergies, anaphylaxis that requires epinephrine, sometimes emergency visits or hospitalization. But there are less severe allergies that people can get with these vaccines. Most of those allergies have occurred in people who are already allergic to something else, but exactly what is, as far as we can tell, non-specific. And there are some people who've had allergic reactions who've never had a reaction before. So the important things to know about them are they do occur, but they are very rare. If you've had an allergic reaction before, there is some increased risk. So there might be a 1 in 50,000 risk that you'll get an allergic reaction as opposed to 1 in a 5 in a million risk, but it's still really low. And every vaccine clinic, you can't run a vaccine clinic in Canada unless you are ready to deal with allergic reactions. That's a fundamental thing about running vaccination clinics. It's why you have to wait 15 minutes after your vaccine to make sure that you're not going to have a reaction. If you have allergies, they'll probably make you wait 30 minutes after the vaccine. So this is uncommon enough that you don't need to worry about it, and people are prepared to deal with it if it happens.
Okay. Dr. Evans, will people get to choose which vaccine they can take? I mean, we've seen various efficacy rates.
So a couple comments. First of all, the efficacy rates to be kept in perspective. Generally, they're all very effective at preventing serious illness, death, or hospitalization. So far, we have not had choice. So healthcare workers have not been able to say, I want this one, not that one. They've been distributed mainly based on practical implications of how easily these things are transported around, whether they're taken to long-term care or whether they're whether you take yourself to a vaccination site. And so far, there's no real medical information that would say you should be choosing one with some important strategy. And so my advice is when your turn comes, do what we all did, just say thank you so much and take whatever you're offered.
Right. Some good advice there. Words of wisdom. Thank you. Let me ask you about travel, because a lot of people are planning that next trip or where they want to go. How will travel, in your opinion, change? There's been a lot of talk about a vaccine passport, Dr. Evans.
Yeah, so I mentioned that the vaccine passport is still just a theoretical concept until we know more about how risky it is for the vaccinated person to transmit the disease. I think international travel will probably slowly start to increase as cases come down and some countries come closer to herd immunity. Don't forget that even if you have been vaccinated, depending upon your personal risk, if you were to get sick, how long since you were vaccinated, and how prevalent the virus is in the country you're going to, whether they have a variant that you haven't been exposed to, all will come into the calculus. The decisions around international travel are going to be complicated for some time. And certainly, we're not going to be, I hope, removing our return home restrictions for some time, because until we've got a good layer of population protection, which, as we've heard from Allison, could be 6 to 10 months away, we really need to protect ourselves from people coming back from other countries. And it's interesting that the three countries who are doing the best on vaccination, the UK, the US, and Israel, all are having worse outbreaks than us at this point. And so I would rather be here than go there, whether it's to get the vaccine or take a vacation, because the more virus there is around, the more dangerous it is for everybody. So travel is not going to be the first part of life to come back to normal, I'm afraid.
So instead of a plan, maybe it's a fantasy for many of us at some point to travel. What happens to people, and I think it'd be good for you both to address this, and maybe Dr. McGeer will start with you. What happens when people refuse to take the vaccine, and how big of a problem is vaccine hesitancy?
So, just at the moment, vaccine hesitancy is actually a good thing, not a bad thing, okay? I'd be really worried about you if you weren't hesitant about taking this vaccine. It's brand new. There's a million things to learn. You want to be making decisions that are sensible and reasonable. And when you know enough about the vaccine, people are going to choose to take the vaccine. And we're seeing that happen all the time. Lots of people a month ago were saying, geez, I'm not sure about this. It came out of nowhere. I don't know about it. I need to know more about it. And then as people have learned more about it, then more and more people are taking the vaccine. We know in the staff and residents of long-term care, generally uptake has been very high. And so there's this element of we want a degree of vaccine hesitancy because we want people to be making informed decisions about what the right thing for them is. And then after that, it's the vaccine at the moment is organized to protect individuals, and people have to make a decision for themselves about whether they want to be protected. I suspect that for those of us who are on the wrong side of 60, that's a pretty easy decision, and it'll be like flu vaccine, only probably more so. That all of us are well aware of the risk that COVID poses to us, and we will be lining up to get vaccines. The bigger question is what's going to happen when we get down to 20-somethings, where if this vaccine does prevent transmission, okay, so that's the first if it does, and if we want to get them vaccinated to slow down transmission, what's their calculus going to be? 20-somethings are generally people who aren't that worried about getting sick, and rightfully not necessarily that worried about getting seriously ill from COVID, although, you look at the number of people who are long haulers and who have persistent symptoms afterwards, that might be a good reason. So I think we're going to watch as we go. Partly it depends on what happens to the disease and what more we find out about vaccines, how we decide. But at the moment, people who refuse vaccine are making their own decision, and each one of us is going to be charged with making that decision for ourselves.
before we go to Dr. Evans about that, what is the latest on side effects, Dr. McGeer? Like, what is the latest data telling us about side effects of the vaccine?
So this is a vaccine. If you're old enough to have heard about Shingrix, okay, my standard comparison for older adults is, there's flu vaccine to which you can pretty much get a sore arm and nothing else, and there's Shingrix where there's about a 30% chance that you're going to feel miserable the next day, and COVID vaccine, our current COVID vaccines are somewhere in between. Okay. There is a chance that you will get a fever or, achiness, feel unwell the next day. Chance is higher with second dose of vaccine than the first dose of vaccine. It's not serious, okay? It's just a day of not feeling well associated with the vaccine, but it is a more what we call reactogenic vaccine. So you do feel the effect of your immune system kicking in and dealing with the vaccine on the next day. Not, it's 15 or 20% of people. It's many people just fly right through it, but not everybody.
Okay. Dr. Evans, I just wanted to get your perspective as we close off here, just about how concerned you are about vaccine hesitancy and what happens to people who don't want to get the vaccine.
So we have more of an issue right now with vaccine envy than hesitancy because everyone's keen to know when can I get my vaccine. But as we start to get all those people vaccinated, hesitancy will be a bigger issue. And I think that it's a little bit about who do you trust. And so the people who tuned in today have taken a good step in looking for an authoritative source of information. To me, I'm not really a vaccine or viral. I'm not a virologist. But when I look at my colleagues in infectious disease and related fields, they were all keen to get the vaccine as soon as possible. The data on these vaccines is just stunning. And when I look at my colleagues who are very familiar with what the disease can do to you, emergency physicians, critical care physicians, general internists who've been caring for COVID patients, we were all very keen to get the vaccine because we know just how bad this virus can be. And so if your choice isn't really no vaccine versus vaccine, it's what's my risk of COVID versus the risk of the vaccine. And I hope for every educated person who's taken the time to discuss it with somebody who knows what they're talking about, that will become a much easier decision. And of course, for the hesitant people, we're at 50 million and climbing rapidly. In a few months, we'll have data on hundreds of millions of people. In Israel, they're keeping very close records on vaccine safety and efficacy. Again, the data is just as stunning as the phase 3 data. And when in doubt, go speak to your family doctor who knows your personal health the best and hopefully can answer not just general questions about the vaccine, but any about your personal health. In terms of vaccine refusal, I think we're going to need to know a lot more about what percentage of the population says yes, what the risk is of transmission in settings like hospitals, long-term care settings, before we get to any laws on whether you can work if you're not vaccinated, whether you have to wear a mask if you refuse a vaccine. Those are all decisions that require a lot more experience before we develop policies on them.
Okay. Thank you for that. And I'm glad you really mentioned also, because there's a lot of misinformation out there, and an ounce of expert insight and data is worth tens of thousands of pounds of social media opinion. So I think the people who are here right now are here because they want to hear that authoritative opinion and analysis. And I'm really thankful for you for providing it. That wraps up our Q&A. And I want to thank you all, everyone, for watching and for sending in your insightful questions. As I mentioned, we received hundreds of them. And I want to turn it over to Louis DeMello. He is the CEO of the Sinai Health Foundation, who hosted today's event. Louis, over to you.
Well, thank you very much, Farah, and thank you for doing such a terrific job, because we did get hundreds of questions. So to go through all of them and figure out which ones to ask, a terrific job. So thank you so much. And the demand for up-to-date, credible information is very high. And that's what you got today from both Dr. Howard Evans and Alison McGeer, two experts in their field. So thank you to both of you. And we will continue to keep you updated as a foundation. It is a commitment that we make to you. The next town hall will be in April. So we will send you information about this when it becomes available. And hopefully you'll join us in great numbers as you did today. We feel it's our responsibility to put our health experts to provide clear advice and clear information, up-to-date information, as we did today. We're also very thankful at Sinai Health Foundation to our philanthropic community for their wonderful support, because during this COVID-19, the support of philanthropy has made a big difference in research and delivering care. So thank you to all of you who've supported us, and you can still do so by contributing to the CEO Fund. You are important members of our community. So again, thank you to our speakers today. Thank you also for the Sinai team led by Megan O'Hearn, who've done a terrific job behind the scenes. And with that, thank you, Farah, and I'll pass it over to you.
Okay, thank you. Thank you, Louis, and to the Sinai Health Foundation, and especially Megan, who really went through all those questions, because there were so many of them, and responded to so many of your messages. Thank you, of course, to Dr. Evans and Dr. McGeer for your time, and for you all. Stay healthy, stay informed. And to close us out, I'm going to throw to a special video. It's being created by Sinai Health, and it's called A Story of Hope. Enjoy.
Right now, we have millions of people who have been infected. There's about 1 million people have died around the world, but the level of infection is only 2% or so. So 98% of us are still vulnerable to this disease.
One of the really interesting parts of COVID is that it's a very variable disease. You have some patients who display virtually no symptoms, whereas at the other end you have these sort of longer-term patients who really suffer from symptoms.
Similar to everyone else in a hospital or healthcare facility, COVID has been, a little bit overwhelming. It's certainly changed our perspective in terms of how to reduce risk overall.
There is an end to this, but we've got to be patient, and we can't relax our guard. Mount Sinai Hospital was an epicenter for treatment of SARS-CoV-1, which is the closest relative to the COVID-19 virus. There are physicians here and nurses who lived through that.
My name is Mike Freilich. I'm a clinician scientist. What that means is 80% of my time I'm doing research, 20% of my time I'm seeing patients. Of course, over the past few months, that's mainly been caring for people with COVID-19. It's really about trusting your intuition when you're caring for these patients, and accepting the fact that knowledge will change, and knowledge will change quickly, and you have to be nimble enough to adjust accordingly.
I was here when SARS was around in the early 2000s. The challenge for a pandemic is, how do you suppress the spread of the disease? And one way you can do it is by increasing the testing intensity across the population. And so that's really the underlying motivation, driving development of techniques that allow us to screen thousands of samples at a time. Antibodies are critical in that they're some of the first things that recognize a foreign invader and will attack the foreign invader. And so they really play a key role in your immunity to disease.
So from a transfusion perspective, particularly early on in the COVID pandemic, we didn't have an optimal therapy. There are several studies that have looked at different types of therapies for COVID. One intervention that people are very interested in now is something called convalescent plasma. You take someone who has recovered, you take part of their immune system in plasma to give it to someone who's sick with COVID to see if we can assist them in boosting their immune response to get better faster.
The great things you can do with machine learning is you can take the large data sets and try and find structure in them. So for example, try and find different groups of patients to explain the sort of heterogeneity you see in clinical response. And if you can do that, you can start to think about instituting guidelines for better treatment decisions.
The intensity at which we are doing studies and experiments is something that I haven't really seen before. We're having meetings at all hours of the day, on Saturdays, on Sundays, late at night, early in the morning, assessing results, designing new experiments, conducting those experiments in the same day. And also the dedication of the team of people who are actually doing the work is really amazing.
It is humbling to be able to care for people who are sick, be able to reassure them, and to be the physician that's looking after them. It's crystallized the importance of not only really good patient care, but also being part of a research process that allows us to improve the care of people with COVID-19.
We now have this sense of purpose that's really renewed and re-energized. And I think that's going to be true for the next coming year. As vaccines become available, the kind of work that we do will become even more essential. And